Okay, so we're going to move on to a sort of a practical session where we're going to try to address a variety of issues that relate to the actual procedure. The first speaker is Dr. Horton from Tesla Cardiac Arrhythmia that is going to talk about tips and tricks to prevent complication during LA appendage exclusion.
Thank you, Andrea. Can you load my slides, please? Okay, thank you. So, I think it's this.
Can we have a pointer?
I guess the mouse works. All right. So I was asked to speak about tricks, little minor nuances, things that make it less likely to have problems and complications. Let me first disclose that this talk was supposed to be given by Dr. Carr, and he is, I think, on a plane right now. Should be landing later this morning. I was kind of given warning a few days ago that I'd be his backup, but I could use his slides, and his slides didn't come. So I was told last night to prepare a talk for this morning using only what was on my laptop. So I feel very much, if any of you guys ever saw the show MacGyver, this is like that. I got to give a talk before the bomb goes off. So anyway, here are my disclosures. So obviously there are, I'm sure, loads of tips and tricks for all of these things. This is only a 15-minute talk, and talking about how to avoid complications with surgical closure is really out of my specialty, so I'm not going to talk about that. I'm going to focus only on the endovascular and the lariat, or the epicardial non-surgical approaches. So left atrial closure, first of all, and let me emphasize this, you actually do need to rely pretty heavily on a certified echocardiographer. When I showed the lariat case where we had a lateral lobe that we were not able to ensnare yesterday, we did have TEE, but it was used by an anesthesiologist. So they're kind of certified to do it, but they're really not the same thing as a certified non-invasive cardiologist. So I think that's kind of a point taken that we may have been able to avoid that problem if we had the right person doing that particular job. So don't underestimate that. I think the talk that was given last hour was just dazzling. A very nice talk about what TEE can do when you have the right person doing that part. So let me start with that. Now with the Watchman, there's a few things I just kind of want to point out. These were just things that sort of came to mind, things that we needed to think about because obviously transeptal puncture is key to putting the Watchman in, but there's some minor nuances, things that you should think about, not just getting, let me just get into the left atrium. There's cannulation of the left atrial appendage, which actually is harder than you might think. Proper sizing of the device, proper orientation of the device, and then sheath management. Now, this is not, there are other complications. There are other things that I will have missed, but these are some of the high points that came to mind last night. The transeptal puncture, exact puncture site actually does matter. So in the old days, when I was first trained to do transeptals, I was trained by interventional cardiologists that had done transeptals without intracardiac echo. That didn't exist at the time, and it was primarily for valvuloplasty. So their experience was in people with left atria that were the size of a grapefruit. And so it's just different. The anatomy is distorted. It's a lot more forgiving, if you ask me, trying to puncture something the size of grapefruit compared to something the size of a small orange. So that's one difference. Ideally, for puncturing for the Watchman, an inferior and posterior site is a little bit better, and I'll show you why in a minute. I think that intracardiac echo is really very helpful. The protocol for the Watchman requires esophageal echo. The problem, I'm not as good at using the information. I'm sure it's there, but understanding what the TEE is telling me with regard to anterior, posterior, it's a little bit hard for me to quite figure that out. I think superior, inferior is pretty easy to interpret there. That's something that you get with great detail with intracardiac echo. So that can be very helpful. Here's just an example of a CT that was rendered and showing the orientation between those different places. Okay, so this is the right atrium here. Let me just run this one more time. And as you twist it around, you can see the fossa there. You can see the dent where the aorta is. And I'm going to run it one more time and stop it. Okay, so if you puncture behind the aorta, you can get into the left atrium relatively high. If you puncture low, you'll get into the left atrium, and you have more of a direct shot toward the appendage. If you puncture up here, you're going to have a very bad day because you're going to hit the aorta. If you puncture down here, you're going to have a bad day because you're going to damage the coronary sinus. So we kind of take for granted that transseptal catheterization is safe and easy, and we do it all the time. It is safe. It's easy when you have all of the right equipment and you have the right experience, but bad things can happen from that. Here's just a point of going high along the fossa. What you do is when you come across the left atrium, you're basically riding right along the roof of the left atrium. And then to try and take that right turn into the appendage, it's a really sharp right turn. The lower you go, the more you can angle up gently into there. So your angle of entry into the appendage tends to be a little bit easier. So a very minor difference in where you want to puncture. So taking an extra 3 minutes getting the puncture right can save you 40 minutes in trying to get the procedure done. Here's just an example of just the left atrium, cutting out and seeing the opening to the left atrial appendage there. As was pointed out in the last talk, the appendage tends to be an oval. The ridge tends to be a fairly rigid structure, and so it changes the shape of and orientation of the appendage considerably. Next slide. It's not advancing, please. Can someone just advance to the next slide, please? Okay. So cannulation of the left atrial appendage. You'd be surprised how difficult that was, and actually how many of the effusion complications with the original PROTECT AF trial were not entirely puncture related, but more cannulation related. The interventional cardiologists tend to approach cannulating a structure a little bit differently than EPs, and both of them had problems. EPs would tend to pull out a solid deflectable catheter to get into the appendage because that's kind of what we were used to. And the surgeon or the IC guys would tend to grab an angioplasty wire because that's what they're used to. And so both of those had a tendency to get overwhelmed by the sheath. And if you have something that's overwhelmed by another structure, you can easily cause a mechanical injury. You can sort of lacerate something. And so getting into the appendage is easy if your angle of entry is right. And so that's why it kind of comes back to the transeptal puncture. If you take the time, do the puncture in the right location, getting into the appendage tends to be pretty straightforward. Now, for the Watchman trial, they recommend using a pigtail catheter, which is atraumatic. It has its issues, but it's certainly safer than using a wire or using a solid-tipped deflectable catheter. Now, let me say that when those of us who do left atrial ablations, we use a solid-tip ablation catheter in the appendage all the time, but what's different is this is a pretty big sheath, and this sheath is still capable of overwhelming the catheter, and so having a different dynamic there than what we're accustomed to either. Now, proper sizing the device, we saw that as an issue yesterday with the Amplatzer device, and it's clearly an issue with the Watchman too. Device migration is, at least in my opinion, the worst thing that can happen with a device. That usually requires a surgeon to fish it out wherever it ends up being, and clearly can be life-threatening and potentially fatal. So I think getting the size right, making sure the device is seated properly, it's not going anywhere. You don't want it oversized, but I would rather it be a little bit oversized than at all undersized so that migration does not happen. So getting the dimensions exactly right is key. This is just obviously I like messing with CTs. So this is where the circumflex is here. Here's the appendage. This is the typical orientation. By the way, the coronary sinus also runs along here and runs right underneath there. So if you're wondering why the distal CS and the appendage can tend to be isolated at the same time, it's because a lot of times they're actually touching. I mean, there is a fascial plane between them, but the electricity can cross between those two areas. So next slide, please. Thank you. So that's the circumflex there. If you look on intracardiac echo, and I'm a little embarrassed to show this because this is a lot worse than the images you saw last hour. That's the circumflex artery there. It just gives you an orientation of where you're going to measure. So you go from circumflex artery over to Coumadin ridge. Next slide. And this is just sliced through the CT using roughly the same orientation. So this is the circumflex. Gives you some idea. For those of you who are not used to looking at TEE, it tells you exactly why we use that as a marker or a border on the anterior aspect of the structure for measurement. Now, the other point that was made last hour was the appendage is not circular, so you can't just take one measurement. You got to look in several obliquities. It tends to be much more oval, so if you're measuring parallel with the ridge, it tends to be longer than this particular relatively short axis relative to the appendage. So one question is, do you average those numbers? I don't really know the right answer for that. All I know is that whichever one of those is the largest number is probably what you need to go with, because I would rather this be a little bit oversized than undersized. So once you measure it, you have to make sure that it's at least 10 to 20% larger than the largest osteal dimension that you saw. You want it to be compressed. You want it, once it gets compressed, to have a certain shape to it. If you look at these things when they're deployed but just standing on your desk, they look a little bit like a bell pepper, maybe an apple, something like that. To me, and I'm from Texas, so I think they need to look like a jalapeno. So the angle of orientation into the appendage makes all the difference. You want the sheath tip to try and be as coaxial with the ostium as possible. And again, this comes right back to the transeptal puncture. An extra 5 minutes here saves a lot of time getting into the site. Now, sheath management is actually a pretty big deal, particularly when you use the pigtail catheter. One of my reservations about using the pigtail was, think about it. You put the pigtail in, you're extending it beyond this large sheath, you're advancing it into the appendage, you're advancing the sheath over it, and you're wanting it to be fairly deep inside the appendage, and then you pull the pigtail out. And then you want somehow not to have any bubbles in your sheath system, because if you do, and then you advance your device, then you're just simply going to extravasate or embolize that area. So the things you have to do, if you're going to use a PIG, which is what they recommend, either insert everything under saline and with simultaneous infusion to try and eliminate or prevent air from getting in at the hemostatic valve. You also probably want to allow passive bleed back of the pigtail catheter before you advance anything into the guide system. Now that actually, what kind of anesthesia actually doesn't matter with this. If the patients are under positive pressure ventilation, there's no problem. If they're not, and they take a deep breath, you can actually have negative pressure in the left atrium. You could potentially have them aspirate air directly into the left atrium. So we tend to do these on positive pressure ventilation, so we take it for granted. But if you're not doing that, you have to think about that, because passive bleed back may actually not work. It might actually make things worse, so avoid that. So with the epicardial non-surgical, I've got like 2 minutes left. Proper LA anatomy is important. You tend to want appendages that have very simple anterior lobes. You want to try and avoid secondary lobes because it does make it more difficult, particularly if that lobe sits behind the pulmonary artery. A lot of times you're not going to be able to get the lariat all the way around that. You want to avoid appendages. The company will say 4 centimeters or larger. You can probably get away with a little bit longer than that. The thing you have to keep in mind is that you could probably get the lariat over a 5-centimeter appendage because before the appendage is snared, it's a little bit like a water balloon. You could probably sort of coax it over there. The problem is the minute you snare it, if it's full of blood, it becomes very stiff, and you won't be able to get the lariat off. That would be the problem. So here's just an example of some appendages. This one I would probably avoid. This one you might be able to get away with, but there'd be a little bit of a risk. Once it becomes stiff, you could probably get over that. You may have trouble getting back off of it there. So the company would probably shy away from this. This one, you probably, it looks weird, but I'll bet you can get over that one without much difficulty. And this one's pretty straightforward. That one would be an ideal one for this technology. So epicardial access, you got to know how to do this safely before attempting this procedure. So this should not be your first epicardial access ever. Even in experienced hands, the complication rate's around 4%, and that's in people that do this, hundreds of them a year. Angle needs to be correct for the lariat. It actually has to be in front of the right ventricle, so it's an anterior stick. If it's too vertical, the wire doesn't tend to go around toward the appendage. It tends to bypass it and go over the PA. If it's too lateral, the wire can flip posteriorly, or it can force the epicardial sheath to have a secondary bend. The trouble is the lariat tends to flip upside down if there's any extra bend. So the lariat works best if everything is straight. If it's straight, you slide it over, quick and easy, no problems. If there's any secondary bends, you can get the epicardial wire to connect to the endocardial wire, but your lariat is going to keep flipping on you. So it ends up being, instead of a 30-minute procedure, a 3-hour procedure, and sometimes you can't get it. Here's just a sagittal view through a postmortem, looking at the different angles of entry. This would be more of an anterior entry. This is posterior, which is what we typically do for VTs. So post-procedure inflammation, this was actually discussed in one of the abstracts. It actually can be pretty profound with these cases. If you're not looking for it, you can do the procedure. They've got no effusion the next day. You pull the sheath. You're tempted to send them home that day. And a day or two later, they actually develop a hemodynamically significant effusion. You drain it, and it's really not blood. This is inflammation. So it can be very profound. And so you have to be on top of that, anticipate it. Colchicine is something that we started using. NSAIDs are something you do as well. The company recommends not using systemic or even epicardial steroids for fear of it so profoundly affecting the inflammation process that it prevents the device from completely sealing. So in summary, begin the left atrial appendage closure program only after complete mastery of each component required in the procedure. That's probably the best way of avoiding complications. Prepare by assembling a team that includes an echocardiography, anesthesia, all sorts of people that are all on the same page. They're all focused on the same outcome. You have to educate the PACU staff to know what to look for, know about these epicardial drains you might be leaving in, things like that. Thank you.